Hello and good afternoon. My name is Ninez Ponce, and I'm the director here at the UCLA Center for Health Policy Research. As a land-grant institution, we would first like to acknowledge the Gabrielino Tongva peoples as the traditional land caretakers of Tovangar, the Los Angeles Basin and South Channel Islands. Thank you for joining us today for today's online seminar. The impact of the ACA on cancer detection among older adults. So it was the Affordable Care Act's birthday yesterday. It's been more than a decade since its signing. The Affordable Care Act is a landmark health reform that drastically reduced the number of Americans who are uninsured or underinsured. Comprehensive research has been conducted here at the UCLA Center for Health Policy Research and at other policy research organizations and academic think tanks, all looking at the ACA's impact on healthcare coverage and access across various racial and ethnic groups, incomes, and ages. ACA research has also looked at improvements in care and outcomes across various health conditions, including cancer, the second leading cause of death globally. Approximately 70% of deaths from cancer occur in low and middle income countries, according to the World Health Organization. Thus, early detection, screening, and management of patients who develop cancer are key to reducing cancer mortality. But just how much of an impact has the ACA had on cancer detection? Additionally, has the ACA narrowed the gap in health access and outcomes for older adults who are approaching Medicare eligibility? My colleague and center senior economist, Dr. Srikanth Kadiala, will share findings of a study he co-authored with senior fellow Dr. Gerald Kaminsky, Jerry, and researchers from the University of Chile on the ACA's impact on healthcare use and outcomes. Looking specifically at older adults near age 65 and cancer detection rates among this group. The study, which was published last month in Health Affairs, found that the ACA helped reduce the cancer detection spike occurring at age 65 by 45%. Dr. Kadiala will walk us through how elements of the ACA, the expansion of Medicaid, private insurance benefits, more affordable individual insurance plans offered in the ACA marketplace, that's covered California, as well as Medicare eligibility, had positive impacts on disease detection among this age group. If you would like a PDF copy of today's presentation, please email the communications department at healthpolicy@ucla.edu. And please stay tuned for announcements for the next seminar on Tuesday, April 13th, with featured speaker, Dr. Susan Babby, Senior Research Scientist and Co-Director of the Chronic Disease Program here at the UCLA Center for Health Policy Research. She'll present findings of a recent study on how immigration policies, such as the public charge rule, can impact the health and well-being of immigrant communities, highlighting their reluctance to use public programs out of fear that they may jeopardize their status. We will also be hosting a California Health Interview Survey data user training webinar on April 9th for legislators, policymakers, and media, and where our team will walk participants through how to use our CHIS data tools, including our COVID-19 dashboards. We'll put the registration link in the webinar chat section, and I hope you can join us or spread the word for others who'd like to join. So now I'd like to welcome my colleague, Dr. Srikanth Kadiala. Srikanth?
Thanks, Inez, for the really nice introduction. So the title of this talk is The Impact of the ACA on Cancer Detection in the Older Ages. This is joint work with Fabian Duarte, who is an associate professor of economics at the University of Chile, Jerry Kaminsky, who's a professor in the Department of Health Policy and Management at UCLA, and is also a senior fellow at the center, and then Antonia Riveros. She was a graduate student at the University of Chile. So the outline of the talk is we're going to just briefly touch upon cancer and the important distinction between sort of screening and diagnostic testing. Then we're going to review some of the literature on the relationship between insurance status and cancer detection. And we're going to focus on the prior literature on Medicare effects. And in particular, two studies from this literature, which are really important for the work that we just published. Then we're going to talk about ACA policies that are related to cancer detection, and we're going to focus on the policies that went into effect in 2014. Then we're going to talk about the results from our study, the effects on cancer detection, and then a discussion and conclusion. So cancer is defined as uncontrolled cell division in the body. Abnormal cell growth typically starts in a single organ, and over time, if unchecked, spreads to other parts of the body. Now, there are more than 100 cancer types defined by organ or tissue of origin. Breast, colorectal, prostate, and lung cancers compose approximately half of total new cases that are detected in a given year. Now, even within a single cancer type, for example, breast cancer, there are many different subtypes which respond differently to treatments. Now, with respect to detection, earlier detection increases treatment effectiveness and long-term health outcomes. Now, we know this primarily from randomized controlled trials of screening for breast cancer, colorectal cancer, cervical cancer, and lung cancer. In these randomized controlled trials, people randomized into two different groups and are offered screening in one group and usual sorts of care in the other group. And these trials find that being offered screening improves long-term health outcomes, especially mortality. Now, with respect to detection, there are two primary forms of detection. And the two forms are sort of screening versus diagnostic testing. Now, screening refers to asymptomatic test use. And historically, there's been screening for 4 cancers: breast, colorectal, prostate, and cervical. For breast cancer, mammography is used. For colorectal cancer, there are several different types: fecal occult blood test, colonoscopy, sigmoidoscopy. For prostate, the PSA test, and cervical, the pap smear test. Now, more recently, screening has been recommended for lung cancer. This is very recent, sort of 2014. I think the recommendation is for 55-year-olds who have a prior history of smoking. Now, diagnostic testing refers to symptomatic test use. So if someone goes into the physician and they say, I have some pain, or they have some signs of excess growth, sore throat, then the doctor orders some tests and tries to diagnose what's causing the problem, what's causing the symptoms. Now, so for the majority of cancers, there is no screening. There's only symptomatic detection. Now, what's the relationship between insurance and cancer detection? Now, there's a large social science literature on the relationship between health insurance, healthcare, and health outcomes. Now, this literature started out with looking at cross-sectional comparisons of outcomes, such as healthcare and health, for people with and without health insurance. So here's data from the Behavioral Risk Factor Social Survey from 2012. This is a year that's in between the years that we analyze later in the talk. And what it shows is, it shows the rates of mammography use in the past year for people uninsured, which is the blue line, and people insured, which is the red line. And what you see is that there's a large difference, almost a 40 percentage point difference between getting a mammogram in the last year between the uninsured and insured. So for an uninsured person, they have approximately 30% in the 50 to 65 ages get a mammogram in the last year, and an insured person, almost 70% get a mammogram in the last year. And the other thing you notice is at age 65, everyone shifts into Medicare in the United States, so more than 99%, I believe. And so there's only one line after age 65. Now you can look at figures like this. You can for colonoscopy in the past year. Here you see the uninsured. They have a 5% approximately get a colonoscopy in the past year, compared to the insured, we have a 15%. Here's the fecal occult blood test. Again, you see about a 5 percentage point difference. That's a 100% difference. And PSA test in the last year. Here you see a difference, sort of 10% versus 30%. And pap smear test for detecting cervical cancer, you also see a large difference. Two other studies of interest here are that Halpern et al. In 2007-2008 work. They find that uninsured and Medicaid patients were significantly more likely to be diagnosed in advanced stages of cancer when compared to individuals in other insurances. Now, the key question in social science, we always deal with this question which is, do the previous figures and results show a causal relationship between health insurance status, test use, and detection, or do they only show a correlation? Now, in cross-sectional data, there are many differences between insured and uninsured, including income, education, and age. It's also possible there are other differences related to underlying health status and preferences for medical care. So it's difficult to know whether the identified cross-sectional differences that you saw in the figures before and in the studies from Halpern are only due to health insurance. So another way of thinking about this question is, if you covered the uninsured, will they utilize tests at the same rate as the insured? Or would you see an increase in detection in earlier stages due to coverage? Now, those questions are difficult to answer in cross-sectional data, but in the mid-2000s, there's a large literature that grew around understanding the effects of Medicare on outcomes, healthcare outcomes, and health outcomes. And what these studies take advantage of is that in the United States, nearly all individuals transition into Medicare at age 65. And this transition allows for an evaluation of the causal relationship between health insurance coverage and outcome variables of interest. And this literature is extremely broad. I'm only going to focus on two studies, but there are a lot of interesting studies in this literature. And outcome variables that have been studied include healthcare utilization, physician visits, cancer test use, cancer detection, mortality for certain conditions, including cancer, self-reported health, and even death. I'm going to focus on two studies. The first one by McWilliams, Zaslowski, Mira, and Ayanian in 2003. And what this study does is they take a nationally representative sample of individuals who are 60 to 64, and they categorize them into three different groups. One group, which is continuously uninsured over the 60 to 64 ages. A second group, which is intermittently uninsured, which means that in 1 year, they could be insured, and then another year, they could be uninsured, and then back to insurance. So they go back and forth between coverage. And a third group, which is continuously insured. And this group, you can imagine, is sort of employer-sponsored health insurance, people in the individual market, Medicaid. And they categorize the 60 to 64-year-old individuals into these three groups, and they look at how utilization variables change as this group shifts into Medicare. And one outcome of interest for us is they find that the continuously uninsured see a 20 percentage point increase in mammography test use as this group transitions into Medicare. This compares to a 14 percentage point increase in mammography test use as the intermittently uninsured group transitioned to Medicare, and only a 5 percentage point increase in test use as the insured group transitions into Medicare. So you're no longer comparing individuals directly, uninsured and insured individuals directly. You're following the same individual over time and looking at how Medicare affects the different groups. So this is slightly different than cross-sectional, looking at just direct cross-sectional correlations as we were previously. Now, the other interesting set of work is by Carr, Dobkins, and Masis, and they use regression discontinuity methods to estimate the effect of Medicare and outcomes for the population as a whole. So these two papers, they don't divide people into different insurance categories. They look at essentially the entire population as the population transitions into Medicare at age 65. And so just a brief background on regression discontinuity methods. What these papers and the papers and our study, the way to think about this type of method is that the X variable in our case is going to be age. The red line is going to be age 65, which is when everyone shifts into Medicare. And the outcome variable are things like cancer detection, mammography test use, physician utilization, and you're trying to see a break in this dependent variable precisely when your treatment goes into effect. In this case, treatment is Medicare. And they find that Medicare eligibility causes a sharp increase in healthcare utilization precisely at age 65. And they particularly find larger increases in utilization for race and ethnicity groups with lower rates of insurance coverage before age 65. So if you ever looked at the health insurance coverage data, what you notice is that non-Hispanic African Americans and Hispanics have much lower rates of coverage compared to non-Hispanic whites as they enter Medicare. And so you would expect if Medicare was if insurance is what's driving the results, you should expect larger effects for these groups compared to the non-Hispanic white group. Now, similarly, Decker also uses regression discontinuity methods and identifies the discontinuity in mammography test use of 4% precisely at age 65. So when Decker looks at, applies sort of this method where for the outcome variable is mammography test use in the past year, she finds a break at age 65 about 4 percentage points. What's interesting, I think, from this work is that the McWilliams, Mira, and Zosowski and Ayanian results suggest that the RD results identified by Card et al. And Decker are driven by Medicare effects on the uninsured. That's because if you take a weighted average of the results from the first study, you actually match up with the Decker mammography results from the second study. Now, here's the final interesting, I think, set of results from this prior literature that's related to our work that we're going to show is we're going to apply the RD, regression discontinuity methodology for looking at cancer detection. And here on the x-axis, you see age, and the age goes from 55 to 75. On the y-axis, you see the cancer detected for 100,000 individuals in that age group. And what's pretty clear in this figure is that cancer detection increases pretty smoothly with age in the under 65 ages. So from 55 to 64, it's a pretty smooth increase. And that's what we expect from our understanding of epidemiology and biology. But what we also notice is that there's a much larger increase going from 64 to 65 than what you might have expected if you just used the 55 to 64 ages to predict what would happen in 64 to 65. Another way of looking at this data is you can take the difference between any two data points. So you can look at the difference between going from the increase in detection that goes from 55 to 66, and you can also look at the difference from going from detection from 56 to 57, and so on. And you can plot out those differences, and you see that the difference in going from 64 to 65 and the detection rate is substantially higher than the difference that you calculate from going from any other age to any other age in 1 year increments. So in the under 65 ages, the slope is approximately 70 cancers per 100,000, but going from 60 to 65, it's an increase of almost 150 cancers per 100,000. And the RD methodology, when you see a graph like this, it's essentially what it does is it takes the difference between the highest point at age 65 and sort of the average across these other data points. So now we turn to the ACA. Now, what were the goals of the ACA? Now, some of the key goals of the ACA were to lower the number of the uninsured. The goal of the and a few different features of the ACA played into this. One is the Medicaid expansion to older new populations. There's creation of health insurance exchanges and subsidies to encourage participation on exchanges. There's the dependent care expansion, which allowed individuals 19 to 26 to stay on their parental ESI plans. Now, there's also better coverage for enrollees in individual and small group markets. Now, better coverage has two features. One is the ACA required a lower bound for the actuarial values of plans that are offered in the individual markets. And the actuarial value is what the plan is expected to cover of a person's expenditures when they're using their health insurance. And they establish a lower bound of 60%. And other plans that are also offered on the exchanges had higher actuarial values. The other feature is sort of essential health benefit provisions. And the ACA required that plans cover certain types of services. And these services were related primarily to prevention and earlier detection of disease. And some of these services were related to cancer detection tests, both screening and just detection diagnostic tests. Now, it's important to evaluate the effects of the ACA on coverage, healthcare utilization outcomes. One key question is, what are the costs and benefits? What would we be giving up if the ACA were repealed, which was almost done in the previous administration? Now, there's a huge literature on ACA effects summarized recently by Gruber and Summers. There are broadly a set of papers on ACA effects on coverage. These look at the effects of the Medicaid expansions, the individual health insurance exchanges, and the dependent care expansions on insurance coverage. And there are also a set of, we haven't touched on, but evaluations of the ACA cost sharing provisions that went into effect in late 2010 and early 2011. Now, as a first pass, and just thinking about what did the ACA do to coverage, 2014 was when a lot of the Medicaid and the individual market benefits went into effect, features went into effect. And you see a pretty substantial decline in the proportion uninsured in the United States in the 60 to 64 ages. So prior to the ACA, over the 2010-2013 period, the proportion uninsured was approximately 12%. And then this falls to about 7%. So this is about a 40% decrease in the rate of uninsurance pretty soon after the ACA went into effect. Here's another way of looking at exactly the same data. And this shows that in the pre-ACA data, the proportion insured in the 60 to 64 ages was approximately 87%. And so you saw an increase, and as you shifted into Medicare, this change is about a 10 percentage point increase. Then the post-ACA data, there's a larger number of people covered. So about 92% of the individuals already had insurance. And so you saw a smaller change in the number of people who go into Medicare. So one way to think about this data is that the ACA cut the health insurance, the Medicare coverage discontinuity by about 40%. Now, in terms of what do we expect, what are the mechanisms for ACA effects on cancer detection? So one is when the previously uninsured are covered, one should see an increase in the probability of seeing a physician, cancer screening, and diagnostic test utilization. This is something that we learned from looking at the Medicare studies. And you might also expect even benefits for the previously insured. These mostly apply to the individual and small group market individuals. The essential health benefit provisions should increase access to cancer screening and diagnostic tests. And even the higher actuarial value plans imply a lower downside financial risk from treatment, especially for higher cost diseases such as cancer. And this really builds off of these, you can almost think of these as predictions. These predictions really build off of the prior work on Medicare, right? Since this prior work on Medicare is that age 65 is not unique except for Medicare eligibility, all of the prior results we've discussed imply that ACA coverage expansions to the under 65 ages could have significant effects on cancer test use and detection. Now, the one caveat might be that the previous work looked at Medicare, and the ACA coverage expansions aren't offering Medicare to the under 65 ages, but they are offering, they're offering Medicaid and plans on the individual market. So you might not expect the exact same effects, but you should expect some effects, similar effects, I would say. So now our empirical strategy for evaluating ACA effects builds on the prior work on Medicare effects. Now, because ACA health insurance coverage improvements for the under 65 population should reduce any existing pre-ACA utilization cancer detection discontinuities at age 65, right? So the size reduction in what we saw previously in these pre-ACA discontinuities is a measure of the effect of the ACA. Covering the people in the under 65 ages should reduce the size of any of the pre-ACA discontinuities. That's just a prediction that comes out really strongly from the previous literature. And we're going to evaluate this by looking at the cancer detection data that I showed you before from the 2010 to 2013 years. Now we're going to look at over longer time periods, so 2010 to 2016. And we're going to construct cancer detection rates again at the level of calendar year and single year of age. And we're going to use Poisson regression methods to evaluate the evolution of the Medicare cancer detection discontinuity over the 2010-2016 years. And we're going to choose 2014 as the year of interest because many of the large-scale ACA provisions went into effect in 2014. And we're going to test for the reductions in the size of the Medicare cancer detection discontinuity in two ways. One is we're going to use the regression discontinuity event study method. And another way is we're going to use a difference in discontinuities method. And in some of these regressions, we also adjusted for covariates related to socioeconomic status at the calendar year, single year of age level, using data from the American Community Survey. We're going to focus on three dependent variables. We're going to look at all cancers combined, so detection rates for all cancers. We're going to look at breast, colorectal, prostate, and cervical cancers combined. These were the cancers with long-standing screening tests. Then we're going to look at the non-VCPC cancers, all the other cancers combined. And I think this is a useful distinction because for the non-VCPC cancers, since there are no screening tests, if we are seeing effects of the ACA, that would suggest that symptomatic individuals were foregoing care prior to getting coverage. For the VCPC cancers, any effects we find will be some combination of sort of both diagnostic testing and screening, because screening is available for these cancers. We're also going to decompose the detection effects by the stage of detection. We're going to look at 4 categories: early stage cancers, middle stage cancers, late stage cancers, and unknown stage cancers. And the idea is that identifying cancers at the earlier stages would suggest that larger mortality benefits due to the coverage. This is what you saw before. This is cancer detection rates in the 2010 to 2013 years. And we transformed the data to show the huge increase in detection precisely at 2000 at age 65 in these years. And now the question is, what is going to happen to this spike in detection in the ACA years? And when we put the post-ACA data, which you see in the red dots on the same figure, what you see is the spike in detection falls pretty substantially. If you just take difference, the 2 data points at age 65, this is without having to run a regression, you can kind of see it clearly in these figures. You see about a 45% reduction in the size of the Medicare cancer detection discontinuity. But what's happening here is that you've increased coverage in the under 65 ages due to the ACA, and the spike in detection due to Medicare is no longer as substantial. It's no longer as large because coverage is happening in the under 65 ages. Now we're gonna use regression models to look at this figure, and specifically by single calendar year, sort of 2010 compared to 2011 in each of the years. And the regression models are going to have slope terms for the over and under 65 ages. So this captures a normal detection, change in detection with age. Then it's going to have a Medicare dummy variable, which captures the change going from age 64 to 65. And then we're going to have time trends for looking at the time trends to capture any changes in detection that's not related to these other variables. And then we're going to look at interaction terms between the Medicare and the year dummy variables. And these interaction terms, what we're trying to understand is how is the Medicare cancer detection discontinuity changing over time. And the omitted variable, the omitted year in these regressions is 2013. And what you want to take away from this is on the y-axis are the coefficients from these interaction terms between the Medicare and the year variables. And you can see that there's very little change in these coefficients. They're almost all close to 0 in the pre-ACA, pre-2014 years. So compared to 2013, there's almost no change in the cancer detection. It's pretty constant. But starting in 2014, the detection discontinuity falls by a pretty substantial amount. And you can see there's already a big change in 2014, although it's not statistically significant. The confidence intervals cross the zero value. But by 2015, 2016, you see a pretty you see a statistically significant difference compared to the 2013. You can do something similar for the VCPC cancers. Here again, you see a pretty significant decrease starting in the 2014 year. But again, in this case, only one of the 3 coefficients is statistically significant. And then the same thing for non-VCPC cancers. In the 2010 to 2013 years, the the detection discontinuity is pretty constant. There's no change. But starting in the 2014 years, there's a potential fall. Now, the second analysis that we do is called a difference in discontinuities analysis. And the best way to think about this analysis is that it's averaging the values that you're seeing in the 2014, 15, and 16 years. So you're getting a weighted average of all of those coefficients. Similarly, for the BCPC cancers, you're going to get a weighted average of what you're seeing in these 3 points. And then same thing for the non-BCPC cancers. And in the difference in discontinuities analysis, when we run the cosine regression models, what we estimate is that the Medicare cancer detection discontinuity drops by about 59 cancers per 100,000 in the 2014, 2016 data years. Now, this is a 45% reduction in the size of the cancer detection discontinuity compared to the pre-ACA years, 2010 to 2013. And when we decompose this 59 cancers per 100,000 change into the BCPC, which are the breast, colorectal, prostate, cervical cancers, and the non-BCPC, we actually find a larger percentage share is coming from the non-BCPC cancers. So 60% of the 59 cancers are coming from the non-BCPC cancers, and then 40% of the 59 cancers are coming from the BCPC. Which I think is slightly surprising, because you might have expected screening to come into play in a larger way than sort of diagnostic testing due to the coverage effects of the ACA. Now, we also decompose these 59 cancers per 100,000 estimate by the 4 staging categories. And we look at early stage, middle stage, late stage, unknown stage. And you find that approximately 53% of these cancers are in the early stage, 15% are middle stage, and 20% are late stage. And 12% are just unknown stage in the data. So they're either missing or they're difficult to classify. So those are our primary results from our study. Now, I think some of our main takeaways are that the 2014 ACA provisions reduced, this is our key takeaway, is reduce the size of the existing cancer detection discontinuity by 45%. Now, I think what's really interesting about this study is that the results not only show the importance of the ACA for cancer detection, but they also implicitly show that health insurance coverage is the mechanism behind the prior results in the Medicare literature. And I think the way to think about this is that if you covered all these individuals in the under 65 ages, but we didn't find a reduction in the size of the Medicare cancer detection discontinuity, that would make you really wonder what was driving all of the previous results. And I'm happy that we found a reduction, because it would be really difficult to understand this entire previous literature if we didn't see a reduction in the size of the Medicare cancer detection discontinuity. Now, the stage of cancer detection results also imply positive potential for positive health benefits from the detected cases. I think there are kind of two ways of looking at these results. One is that we are finding cases in the earlier stages, but the other way of thinking about these results is, imagine we found that the majority of cases were found in the later stages, then the implication of that would be that you actually have to start screening significantly earlier. So I think there's 2 different ways of thinking about the implications of the cancer staging results that we find. We also found a reduction in the non-BCPC Medicare cancer detection discontinuity. Now, this really suggests that the symptomatic individuals are foregoing diagnostic testing due to the lack of health insurance. I think there are some small scale studies of interviews with individuals who don't have insurance. And what really comes through in these studies is that people do defer care because they don't have coverage and they don't have the financial means to afford the care. And so I would say that these results support those type of studies. But we should mention that these results also suggest that there's some scope for incidental cancer detection. And incidental cancer detection is, imagine you're an individual who hasn't seen a doctor in a long time because you didn't have insurance. Now you get insurance and you go see a doctor and you report a bunch of different things and the doctor does a bunch of different tests. And while they're searching for something else, they end up finding cancer. And so I think covering, incidental cancer detection, there's definitely scope for that when you're covering, especially populations who've been uninsured for a significant period of time. If you think about back to the McWilliams studies, this would be the group that's sort of continuously uninsured in the 60 to 64 ages. Finally, I think our results also strongly imply that continued increases in coverage for the uninsured and underinsured in the individual and small group markets will lead to additional reductions in the size of the Medicare cancer detection risk community, right? So what we notice is that even in the post-ACA data, in the red dots, that even in the 2014-2016 period, when you did see pretty substantial increases in coverage at 60 to 64 ages, you're still seeing a pretty sizable increase in detection at age 65. So our results would suggest that continuing to cover the remaining uninsured and underinsured in the individual and small group markets would continue to reduce the size of the remaining Medicare cancer detection as well. Now, finally, I think our results add to a developing literature that shows the importance of the ACA and health insurance generally for disease detection. Now, this includes recent work by Sony et al., where they show that the Medicaid expansions increase cancer detection by approximately 14 cancers per 100,000 individuals. And they also use SEER cancer registry data, but they look at, they don't necessarily focus just on 60 to 70 ages. They look at the entire age population. And what they do is they compare states that expanded Medicaid to states that did not. And they find that Medicaid expansion increased cancer detection by approximately 14 cancers per 100,000. There's also earlier work that's described by Sabic and Andulin, and they show that the dependent care expansion, so this was the coverage expansions for the 18 to 26-year-olds, increased detection, cervical cancer detection for that group. And there's also, and sort of getting away from cancer for a bit, there's also work that shows that the ACA finds effects on diabetes and cholesterol diagnoses. And so and I think especially in the last 10 years, when there's been a focus on thinking about how does health insurance affect disease detection, there's a large body of evidence that's built up that it's very important for not only, it's very important for detection. So I think a lot of the prior work before that showed that it was important for treatment. So once you've been diagnosed with something, having health insurance leads you to getting better care, more tests, more surgeries, chemotherapy, all the necessary things that you need to treat disease. But I think since approximately 2010, I think there have been a bunch of studies that now show that health insurance is also really important for finding disease at earlier stages. Just thinking about sort of next steps, we think it'd be really interesting to examine this exact same research question using the national program cancer registries data, which captures cancer case information for the entire US population. Yeah, I should have mentioned that the data that we're looking at, the SEER registry data, captures information on 37% of the population. And so it'd be interesting to see if we find similar effects when we look at the entire US population as a whole. And then finally, this goes back to the earlier Medicare effects papers that I was discussing, where Hart, Dobkins, and Maces show that Medicare had larger effects for non-Hispanic African Americans and Hispanics because they had lower rates of health insurance coverage in the under 65 ages. And similarly, if you look at the data, and this is some of the work that's been done at the center and also by Buckmiller and Levy, the Affordable Care Act had substantially larger effects on health insurance coverage for Hispanics, Latinos, and also non-Hispanic African Americans. So the Hispanic change is extremely dramatic. It's prior to the ACA, 3 out of 10 Hispanics, Latino population were uncovered, and that drops to by about 15 percentage points. So it goes down to about 1.5 out of 10 individuals post ACA. And that's much larger than the change that you see for non-Hispanic whites. And it's also larger than the change you see for non-Hispanic African Americans. So it'd be really interesting to know, are there comparable absolute and relative changes in the size of the Medicare cancer detection discontinuity for this group? Which is what you might expect, given the significantly larger health insurance coverage changes. And that's the end of our talk. And we're happy to take some questions at this point.
Thank you so much, Dr. Kariala. Good afternoon, everyone. My name is Tiffany Lopes, and I'm the communications director here at the UCLA Center for Health Policy Research. We're going to be going through questions from the audience today, so I encourage you to continue to ask your questions using the Q&A function in Zoom. We've got a couple of questions, so let's start with the first one. Are there any specific recommendations of the U.S. Preventive Services Task Force on Cancer Screening that may potentially be revised based on these results?
I don't think so, and it's primarily because we look at detection, and we haven't broken down the results in terms of staging by the cancer type. So we haven't looked at necessarily staging for breast cancer or prostate cancer in terms of the stage of detection for those cancer types. And I think the USPSTF, these types of recommendations, they really think about staging and also how treatment interacts with staging. And so for them, I think they would need to see more than simply the detection increase, but they would also need to see the stage of detection for each of the different cancer types. And we haven't done that. And one of the reasons we haven't, I think we can possibly pursue that, especially if we start going to the National Program Cancer Registry data, where we can look at the full country. But we haven't done that because if you think about our results are large in the sense that we see almost 40% decrease in the cancer detection discontinuity, but it's also 59 cancers per 100,000 for all the different cancer types combined. So if we start cutting the 59 cancers into sort of say breast cancer, prostate cancer, it's going to be hard to identify changes in individual cancer. I think it's going to be hard. I think we can try, but it's going to be hard. And I think that kind of data is required for USPSTF to change their recommendations.
Thank you. Do we have any evidence yet on whether increased detection has translated into reduced cancer mortality? It'd be nice to know what impact these detection changes have had on health outcomes.
We don't, and we haven't pursued that question, and primarily because the RD methodology is really useful for identifying breaks in things like detection. But mortality, if you think about mortality for cancer, even for the majority of cancers, the 1 year survival, you have survival rates that exceed 1 year. And so you're no longer, to identify mortality changes, you have to follow people over time. To really identify mortality difference, you have to follow people over time. And what that means for the RD methodology, at least the way we've implemented it, a lot of people would age into Medicare, or similarly, it would be, you'd have to use a different methodology, and I think it would be difficult. I think the better way to do it would be to combine these detection results with some microsimulation results. There are a lot of microsimulation models that tell you something about what it means for mortality for finding cancers at an earlier stage. And I think that might be a better way to do it than estimating directly from the data. But that's a really interesting question, and we should think about doing something like that.
Sounds good, thank you. How may the findings of this study inform or influence care for older adults? And how does it differ with that of recommendations of care for younger adults less than age 50?
So I think our results apply the older ages because our results are the RD methodology is really focused on identifying effects for the people near age 65. So in that sense, it's difficult to take our results and apply them, I think, directly apply them to ages that are far away from age 65. Now, I think if you want to think about how the ACA changes have affected other age groups, I think the Sony et al. Paper is much more informative about the effects of detection of the ACA on detection for individuals all across the age distribution. But I think that's always sort of a criticism of the RT methodology, is that it really applies to the groups where you see the change in treatment. And in our case, the change in treatment, which is offering, which is the ACA, it applies to the under 65 ages.
Thank you. We have one more question right now. So if anybody has any last minute questions, please feel free to drop them in the chat. Oh, we did get one. So would it be a stretch to say that data from this study could be used to inform stakeholders such as insurance companies like Medicare to cover more services for older adults?
I think it's, I have to think about it a little bit. I'm not sure what our study, I'm not sure what the implications are for our study from Medicare, but it does have implications. I think the direct implications that it has for policy and policy and thinking about other insurance expansions is that I think it does pretty strongly imply that if you cover more people in the under 65 ages, so you still have an uninsurance rate of approximately 7% or like 5% of the country. If you covered those individuals either through, there are a bunch of states, I think there are about 10 states that haven't expanded Medicaid. You expanded Medicaid in those states. I think you would see pretty substantial increases in detection through the expansion of coverage. So I think it has implications in that direction. At this point, I'm not quite sure what the implications would be for the Medicare population.
Are there any data or consideration included in the study about overspending on screenings? Is there any fear, whether logical or illogical, of increasing the financial burden of the ACA from expensive screenings that weren't necessary, even though the individual feels little to no cost due to Medicare?
Yeah, that's a really good question. I think to think about, I think one aspect of our study that touches on this question is that we do find detection that happens in earlier stages. I think one additional thing that we can do is we can break up the staging categories into finer categories than what we've done. And so here's a good example. I think if you think about something like breast cancer, I think there's a lot of question about whether you should be finding in situ breast cancers. There's a big debate. And so we can think about, well, maybe we can do finer categorizations of our detection estimates to see, are there cancer types like the in situ cancer types? So can we decompose our 59 cancers per 100,000 estimate into finer characterizations? And if we found that, I doubt we will, because I think our staging results at this point would say no. But if we did find that in situ cancers like the in situ cancers were a significant part of our findings, then that would suggest overall utilization and sort of unnecessary detection. But I think given that we found a substantial amount in the middle stages, in the middle categories, I think this is less of a concern, but I think it's certainly worth exploring.
Thanks. Has your study been used to compare the implications between the states that expanded ACA and Medicaid versus those that did not?
Yeah, it hasn't. I think that's a direct implication, as I was mentioning. And one thing that we want to do, I think, in the next step, and we can do if we had sort of the larger databases, sort of the detection data for the entire country, is we can try and say how much of the change that we saw is due to specifically to the Medicaid expansions. So I think we can do that analysis, and at that point, that result would directly apply to sort of expansion of Medicaid for the states that haven't expanded Medicaid. But we haven't done that. But I think that's certainly worth doing.
And then as far as any upcoming research, we did get a question from somebody who's asking if it's possible to get involved with the research. Are you looking for graduate students or doctoral students to help?
Yeah, I think we'd always be interested in working with graduates. And yeah, so please just email me. I think you can find my email address on the web.
Sounds good. What type of community partnerships and thus outreach has been most helpful in spreading the word about symptoms that more predisposed communities should be aware of?
I don't have I'm not sure how to answer that. I'm not sure. I have to think about your question a little bit.
That sounds good. If the person who asked that question can put their email in the chat, otherwise you can email us at healthpolicy@ucla.edu. So those are all the questions that we have for today. I just wanted to thank you all for attending this month's webinar, and a big thank you to our presenter, Dr. Kadiala. We will be posting a recording of this webinar online with closed captions within the next 2 weeks. So please visit healthpolicy.ucla.edu. As a reminder, if you'd like a copy of today's presentation, please email us at healthpolicy@ucla.edu. And stay tuned for details on our next webinar on public charge on Tuesday, April 13th. Have a wonderful rest of the day. Thank you.
Yeah, thanks so much, everyone.